Hi, today we are talking over our second set of questions with developmental disabilities. So, the first question in the set asks which of the following physical examination findings in a newborn infant should cause the clinician to suspect a genetic disorder? And of those offerings, the answer would be cafe au lait spots. And cafe au lait spots are brown macules. They can be found anywhere on the body. When we start to worry as a clinician if there are 6 or more, and if they're greater than 1.5 centimeters, that could be an indication of NF, neurofibromatosis, which is a genetic disorder. And that would be grounds for genetic referral. As far as the other offerings, other answers, some subconjunctival hemorrhages, really common to see during the birth trauma process. So we would not be suspecting a genetic disorder based on that. Malaria are just black sweat glands, really common in newborns, wouldn't be an indication for concern. And the last answer, vernix caseosa, that's a normal finding in newborns. That is the whitish, gray, greasy covering that covers the babies when they're born in the birth process. So we would not suspect a genetic disorder with that. Question 2. A child with cerebral palsy who uses crutches is being monitored for a curvature of the spine. Which thoracic curvature is an indication for treatment with bracing in an adolescent with scoliosis? And that would be with cerebral palsy or not cerebral palsy, so it's a good thing to know. Scoliosis is a lateral curvature with rotation of the vertebrae, and it's typically thoracic or lumbar when we see it. And we do allow some degrees of curvature with variations because we do see that during the growth process where there can be change in the degrees of scoliosis. But less than 20 degrees, there is no treatment done. 20 to 40 degrees, we usually put them in a brace. And greater than 40 degrees is indication for surgery, Harrington rod placement usually. So again, the answer to this one would be which is an indication for treatment. The lowest threshold for treatment, which would be bracing, is that 20 to 40 degrees. And again, we frequently see our children with cerebral palsy with scoliosis because of the constant pressure of the uneven gait can cause on the spine. But the tolerance is still the same. Greater than 20 degrees would be an indication for treatment. Question 3. Which of the following is an initial treatment step in an adolescent who presents to the emergency department with status epilepticus? Obviously, seizures are seen in many of our children with developmental disorders who have had neurological insults. So when we're looking at this, one of the first things we should think about is ABCs. So as far as the other questions, let's go through them. And we would want to stabilize that airway first. Now, concurrently, when we're working in an acute care area like the emergency department, we would say one person would be stabilizing the airway and concurrently someone would be starting an IV. So it's not uncommon that we would see these other therapies start. Obviously, if we're worrying about hypoglycemia, which is very, very common in the seizure disorder because it uses up so much glucose for that neurological instability, we would be giving IV glucose at some point. Certainly we would be considered IV medications for the seizures, which IV diazepam, you may see lorazepam, midazolam given, phenytoin, obviously Dilantin, and phenobarb could also be indicated. So again, all of these answers would be good, but the first one that we would be concerned with is the ABCs, so stabilize the airway. Question 4. A mother brings her 20-month-old female child to the office because she noticed pubic hair growing. On examination, the clinician notices the clitoris is enlarged, The rest of the exam is unremarkable. Which of the following is an expected laboratory finding on this patient? This is a little bit complex offering. It's not unusual to have precocious puberty in some of our kids with developmental disabilities if there's been an insult to the brain, either through the birth process or acquired or other types of problems. But for any child with signs of puberty, you're going to want to screen for congenital adrenal hyperplasia. Okay, and obviously the enlarged clitoris is a sign of that, but other signs and symptoms would be pseudohermaphroditism. With a urogenital sinus, sometimes we see signs of virilization, so masculinization too, that can have a problem, or with perhaps some early bloody discharge or blood-tinged mucus discharge, so a sign that hermenses may be coming, so that would be a concern too. These kids are usually deficient in enzyme 21 hydrogenase, and what happens is that there's an increased urinary and plasma androgens, and one of the byproducts of that is DHEA and increased androstenedione. So you definitely want to monitor that for laboratory findings for any female child with early signs of early sexual secondary characteristics. Question 5. Which of the following is a complication of an infection with parvovirus B19? Again, parvovirus is very, very common in childcare settings because of infection control issues, and we always see in areas where it's the school where we have children with developmental disabilities, because they may not be as freely able to move around if there's been an alteration in mobility with hand washing and things like that. So we know they are at risk for that. HPV-19 or parvovirus we frequently see as fifth disease. Okay, that's the other name for it, with the slap cheek appearance, bright red rash on the cheeks, and it's due to a viral infection. But as far as these other things that we see, we would be concerned with aplastic crisis, and because the virus infects the precursor to the erythrocytes, so we would be concerned about that. The good news is, though, that they usually recover spontaneously without any intervention. Very rarely would they require a transfusion for severe anemia. But again, aplastic crisis is something that we would watch out for a child with fifth disease caused by parvovirus B19. Which of the following is a contraindication for meningococcal vaccine? Menamun is one of the most common types that we see. So of those, we want to go back and think about what do we know about the meningococcal vaccine. And again, it's trivalent, and it's an indication for prevention of meningococcal caused by Neisseria. We give it at 11 to 12 years, and again at 15 years. We want the kids immunized before they are college freshmen. Other groups that are given to military recruits, children living in institutional settings that are in group rooms. Again, same kind of contact issue that the college freshmen have. Okay. We give it to microbiologists who might be working with the virus. We give it to all children who may have a functional or anatomic asplenomegaly type. They're functionally without a spleen. So again, a lot of those kids would be kids with sickle cell, that their spleen isn't functioning. So which of the following is a contraindication? Okay. Of those, really the only one that is an absolute contraindication is anyone with a history of Guillain-Barré syndrome. So that would be a contraindication for that meningococcal vaccine. So question 7. An 8-year-old severely developmentally delayed female child presents with seemingly red, itchy right eye with a lot of yellow-greenish colored discharge for 3 days. She denies any injury. Again, could be a poor historian, though. You are unable to assess her visual acuity as being normal, but she does have moderate tearing and mild photophobia. What is the most likely diagnosis? So again, going back to some of the things I talked about as far as children with severe developmental delays, maybe not being as mobile, being able to get to a bathroom freely or a sink freely with hand washing. So we know she's at risk for bacterial conjunctivitis. And actually that's what the answer is. And when we talk through it, the allergic conjunctivitis, again, usually the discharge is tearing, so it's clear. There's a lot of itching involved, okay? They may have a little bit of tearing, usually don't have mild photophobia with that. With viral conjunctivitis, again, it can have some of the same symptoms, but the discharge is usually white, okay? And as far as reactive arthritis or Reiter syndrome, usually with those kiddos we also see, besides the conjunctivitis, it's usually not yellow-green discharge, but we also see arthritis symptoms and urethritis symptoms of the ureters. Again, in Reiter syndrome we usually see in males. This is a female child. So the other thing, though, to think about in a situation like this is it's not unusual for them to have photophobia with just the irritation from the discharge, but with a child that is a poor historian, that you're not able to get a really good history and be confident that she didn't get an injury, I would always fluorescein this patient to make sure that there is no trauma that we've gotten a secondary infection in as far as a corneal infection. So that would be certainly handled very, very differently. Usually, putting a child like this on cortisorin drops or Bactrim drops, tobramycin is another really good choice. So, an autistic child presents with persistent halitosis. The most common cause of halitosis is from which of the following? And halitosis can be caused by a lot of different things. It can be caused by pharyngitis, sinusitis, poor hygiene, any of these. But the number one cause is nasal foreign body. And this is something to consider with a child with autism because they can get fixations with objects. Some of them tend to hoard. Frequently, they can be non-communicative, so they won't tell you, oh, by the way, I shoved this up my nose. And we should always be concerned, especially when it's unilateral and the discharge is green, yellow, foul smelling, okay? And, in my practices, I have seen some pretty unusual stuff shoved in pretty unusual places, but the discharge may be a different color too. I did take care of one child that had purple nasal discharge, unilateral, right after Easter, shoved jelly beans up. Other things that are common, though, as far as the most common objects for them to shove up is beads or seeds or popcorn kernels, things like that. And those are handled very differently. You might be able to irrigate a bead out, or perhaps use suction or a curette if you can get it up around there without causing too much nasal trauma. You do not ever want to irrigate a seed, okay, or anything that's porous that can absorb the water. Cotton balls, sponge. I've had kids that have shoved pieces of sponge up. Again, they absorb the water and they actually end up with becoming more difficult to get out. So keep that in mind as far as if you do know what the foreign body is that you're looking for. Question 9 asks about the eggs of this parasite are detected by microscopic examination of clear adhesive tape that has been pressed to the child's anus in the morning prior to bathing. What parasite is most likely to be identified by this test method? Again, you can do it first thing in the morning. I have had parents say that they can be more successful putting the tape in that area at night, though it tends to be a little bit uncomfortable for the kids all night moving around. But you're most likely to detect, and this is the most common parasite infection in children and a problem with kids with severe developmental disabilities because they may, without understanding of the social norms, scratch themselves in that area so that we can end up with a lot of problems with transfer between the genital area and the GI tract with the mouth and the carrier being the hands, but we're looking for pinworms. And the last question for this set. You're asked to consult for a center that provides care for children with developmental delays in the inner city. It's located in a high-risk area for lead poisoning. At what age would an initial screening for lead screening occur per the Centers for Disease Control and the prevention guidelines? And the initial screening should be at 9 months. Any child in a high-risk area, we recommend screenings 9 to 12 months and then again at 24 months. But the initial should be at about 9 because we want to screen all children between 6 months and 6 years at least twice during that live in a high-risk area, which are a lot of inner cities, places with peeling paint, very old buildings, things like that. So I hope you enjoyed this set. Hope they're helpful to you when you take those boards, and to wish you good luck.